Okay, so how could we measure progress with these goals and get a baseline? So I'll go through a few examples, and the first three tools you'll recognize because we talked about these in the chapter on published assessments and outcome measures. So we might use the EAT 10 because there's a statement there that might capture one of these goals, and it's statement number 3, which is swallowing liquids takes extra effort. And so the client would rate that on a scale from 0, which is no problem, to 4, which is a severe problem. But that's really the only statement within this tool that's probably directly related to her goals. So we might consider a different prom that's even more relevant to her situation. So something like the Sydney Swallow Questionnaire. There's a few more questions on this tool that directly relate to this client's situation. And because of the rating system, which uses a visual analog scale versus the Likert scale in the EAT 10, it's more likely to capture change. So some questions on this tool that could be rated pre and post therapy are: how much difficulty do you have swallowing thin liquids? Do you ever cough or choke when swallowing liquids? How much does your swallowing problem interfere with your enjoyment or quality of life? So that one seems to be a bit more relevant. We could use the COPM. And the beauty of the COPM is that it can be tailored to lots of goals because it doesn't have set parameters to rate like the EAT 10 and the SSQ. So, for example, let's use a goal of drinking without coughing. We'd ask the client to rate how well they think they're doing at the moment on a scale of 1 to 10. And maybe they give that a rating of 5 out of 10. So. Then we ask the client how satisfied they are with their performance, and they give that a rating out of 1 from 1 to 10 as well. And maybe that's a 2 out of 10, so they're not very happy with their performance. From memory, I think I recall using 2 outcome measures with this client, and I know one of them was goal attainment scaling, which I'll just talk about now. So we could use GAS for increasing fluid intake. Currently, she's drinking 4 cups of fluid, and the goal is 6 or 7. I'm not going to go into the complexities of GAS now, but if we're going to use this outcome measure, then I might put her baseline as drinking 4 to 5 cups of fluids per day. And then the next step up, which is her goal, would be 6 to 7 cups of fluid per day. And she's got a tally at home where she records how many cups she has. You can technically measure this without using GAS, but if you want to validate a tool that's going to give you a score as to whether or not the change was clinically meaningful, then go with GAS. And then we could use a visual analog scale or a Likert scale that we've made up ourselves. So if we want to use a visual analog scale, so rating something along a line, we might choose a goal like swallowing without effort or enjoying drinking, because these are really subjective and work well on a visual analog scale. And then Likert scales. So let's say we want to measure coughing with drinking, and we don't want to use the EAT 10 because the way it's rated, which is no problem to severe problem, is a bit more vague and abstract than we'd like for our particular client. So we could create a scale to measure coughing frequency, and maybe that scale is, never coughing, rarely coughing, sometimes coughing, frequently coughing, always coughing, whatever, however you want to make it. So I hope that gives you a bit of an idea of how you can draw out potential goals and how you can measure progress with different tools. Now I'll talk about making them smart. Ugh, I know, I hate SMART goals too.